Good evening, everyone. My name is Dr. Prateek Joshi and presenting to you an ideal case presentation of non-union of a fracture. Now, the most common fracture with which we get non-union is the tibia, and therefore what I've decided is we will put this case across as a case of non-union tibia. Before I start, I'd like to thank Medusane India for the opportunity to collaborate with them, and my YouTube channel is Rapid Revision of Orthopaedics by Dr. Prateek Joshi, where we will be putting up these topics as well as some other theoretical topics as well. So please like, share and subscribe both the channels Medusane as well as Rapid Revision of Orthopaedics by Dr. Prateek Joshi. So without any further ado, let us move on to this topic, which is the non-union tibia in the form of an ideal case presentation. Now, what are the learning objectives for this session? Firstly, we have to create an ideal format for a short case. Now, if you have seen the previous video which I did in association with Medusane, it is an ideal long case format, whereas non-union and such related topics such as chronic osteomyelitis in general are asked as a short case at undergraduate level, and therefore in this session we'll try to create a short case format. Moving on, also a couple of basic theoretical points will be covered which are frequently asked in such a case. Also, we'd like to visualize some clinical examination findings. So I have made some clinical examination videos from a patient and we will look into them and I will describe the findings. And most importantly, we will bring together a streamlined diagnosis consisting of a set of keywords which we can use and get the maximum possible marks in the minimum possible words. Okay, so first and foremost, we must start any short case with either the diagnosis or the positive points in history which are supportive of your diagnosis. So in case of a case of non-union, you will have a history of a high energy trauma in the recent or the remote past. So the patient may complain of a road traffic accident or a fall from a height or some sort of an assault which has happened a couple of years or a couple of months in the past. Second, there will always be a history of suboptimal treatment, such as there could be a conservative management, or the patient could have gone to a bone setter, or they could have been operated in a conventional orthopedic setup with some sort of complications. Apart from that, if there are some complications involved, such as infection or a further trauma or something like that, the patient will often give a history of multiple surgical procedures. Now, if you will see, I have put a plus or minus sign in front of it because this kind of a history may or may not be there. Moving on, there could be a history of infective signs if we are dealing with a case of infected non-union. So a patient may talk to you in terms of a small sinus or a small hole on the skin which is discharging some pus, or we could have the patient himself telling you that the limb seems warm to him or the limb is swollen, so on and so forth. These are of course history signs, and there could be some specific signs. So the patient could experience abnormal mobility at the fracture site. Second, the patient could experience pain at the fracture site when the patient tries to stand or walk on the limb, and most importantly, there could be pain at the fracture site in the case of an infected non-union. We will get to this point a little later in the history. Now, positive points in examination, the things we have to look for here are, firstly, there is evidence of high energy trauma which has caused a fracture. So we could find an abnormal mobility at the fracture site. We could find a deformity where if the fracture has partially united, then the mechanical axis of the limb will not be in the normal anatomical axis. There could be shortening in the tibial or femoral component. We will restrict to the lower limb right now because it's easier in terms of case management, and of course all of these, abnormal mobility, deformity and shortening, will lead to a specific gait of the patient. Moving on, there would be evidence of suboptimal management. If there is multiple surgical procedures, there could be multiple surgical scars. If the patient has been treated with a cast, then some sort of cast ulcer or cast scar could be present. If the patient has undergone external fixation, then we could see the pin tracks or maybe the scars which the pin tracks have left behind. Moving on, as we said, evidence of multiple surgical procedures such as surgical scars may be present. If they are present, then it is very important to see these scars and to note them down in your physical examination that these kind of scars are present. Mention the length, the breadth, the position of the scar and the health of the scar, which means is the scar well epithelialized, well healed, or is it fraught with some kind of a complication. Also, in examination, we must look for infective signs such as pus discharge, chronic discharging sinus, so on and so forth. Now, some specific points in examination. Now, so far we have gone into points which may or may not be present in a case of a non-union. Now, there are some points which are very specific to non-union. So let us take them one by one. First one is pain on weight bearing. So if we make the patient walk If the patient is able to walk, the patient will complain of pain on weight bearing. In case of pain on weight bearing, the patient will try to reduce the stance phase of that particular limb and will try to compensate by putting his weight on the other contralateral limb. Second, pain at rest may or may not be present. Now, this is an important point because as per textbook definition, non-union is painless. But there are some scenarios in which non-union can be painful. The first one is infection and the second one is interposition of soft tissue or incarceration of neurovascular structures, in which case pain at rest may be present. However, if you are asked in the exam, is non-union painful or painless? An uncomplicated non-union is always painless. Moving on, abnormal mobility will be present across the fracture site since the bone is disjointed at the fracture site, and abnormal mobility always has to be seen in two perpendicular planes. So if the fracture mobility is present in two perpendicular planes, that is along the sagittal plane as well as along the coronal plane, then this test is said to be positive. There are some exceptions to this. For example, in case of the lower limb, if you have a malunited fibula in the presence of tibia non-union, it will block the abnormal mobility and therefore the test will be false negative. Also, in case of a pseudoarthrosis, if the amount of fibrous tissue across the fracture site is quite a lot or it is associated with overriding, in that case you could get a false negative abnormal mobility. Therefore, we need another test, and that is called transmitted motion across the fracture site, which means if you were to stabilize the joint above and try to rotate the proximal fracture fragment, then in case of a normal or a non-broken bone, the entire limb should move, which means that the movement in the proximal part of the bone should be transmitted to the distal part of the bone, whereas in case of a non-union, this will be absent. So absence of transmitted motion across the fracture site is a specific sign of non-union. Again, this can be blocked or given a false negative if, for example, the fibula is malunited in the case of tibia fibula fracture or in the case of a slightly more rigid pseudoarthrosis. Moving on, range of motion at the joint above and the joint below must always be checked. Now, let's take a look at some clinical examination videos. Here we have a case of infected non-union and we are inspecting the skin around the fracture. If you can see, the skin is dark, it is atrophic. There is the presence of a particular sinus around the skin, and what we can see is that there are trophic changes in the skin around the sinus. This is classical of a chronic infection. So this was a chronically infected non-union of the tibia and the fibula. Moving on, here we are checking for limb shortening by comparing bony landmarks such as medial malleolus with the contralateral normal limb. Bony landmarks at the upper end, for example, the tibia, the tibial tuberosity or the knee joint line also are compared, and in this case it is also fairly simple for us to find out if the shortening is in the tibial component or in the femoral component. Moving on, here I am palpating the fracture gap. So the fracture gap can be palpated as a cleft between two fracture fragments, and here we are examining for abnormal mobility across the fracture site in sagittal plane as well as in the coronal plane. Also, local inflammation for calor, rubor, dolor and functionalism has to be done. So I am checking the temperature. Remember, it has to be checked with the dorsum of the hand and with comparison with the contralateral normal limb at the same time. Now, here we are examining the sinus. If there is a sinus present, it is important to comment on the nature of the sinus, which is a healed sinus or a discharging sinus, if there is acute inflammation, if there is severe pus discharge, so on and so forth. And last is the range of motion of one joint below and one joint above. So here we are asking the patient to flex his knee joint, both of them together, for comparison with the contralateral normal limb. I'd also like to draw your attention to the fact that there is a lot of movement across the fracture site, which again confirms our finding of abnormal mobility across the fracture site. Moving on, we make the patient walk, and once you make the patient walk, what we can see here is an antalgic gait where the patient tries to reduce the stance phase of the affected limb since it is causing him pain. For understanding purposes, let us loop the video again. Here we are, the patient is reducing the stance phase to prevent the pain. So, at the end of our case, our final diagnosis should be name, age, sex of the patient, followed by important positives in history and examination, include the disability such as the gait, and state the diagnosis. So for the purposes of example, my patient, a 40-year-old male who presented to me with a history of a high energy road traffic accident 1 year ago, and now a chronic discharging sinus in the upper half of the tibia with abnormal mobility present in two perpendicular planes and loss of transmitted motion across the fracture site with one single discharging sinus inferior to the tibial tuberosity, which is discharging intermittently with moderate changes of inflammation around it. The patient is disabled in terms of inability to walk and inability to perform toileting and personal hygiene, and therefore my diagnosis would be a case of non-union of fracture shaft of tibia. This is the way the diagnosis has to be stated. So I hope you enjoyed this video. I have deliberately kept it short because even in the exam you need only about 10 minutes to take the case and another 10 minutes to present the case. So please get in touch with me. My contact email will be given in the channel information. You can get in touch with me on Facebook or Instagram, and please like, share and subscribe, and leave comments for feedback or criticism or anything else that you'd like to say. And our channels are Rapid Revision of Orthopedics by Dr. Prateek Joshi as well as Medusane India. So please subscribe to both the channels and share across to your friends if you like the video. Thank you.